Greetings. Let us learn about EGD, esophagogastroduodenoscopy. How do we set up? How do we pick up the right endoscope? And what are the indications for EGD? What are the contraindications as well as adverse events related to EGD? So when you go into the scope storage room, you will find lots of different scopes: gastroscopes, colonoscopes, enteroscopes. For EGD, you need to pick up the gastroscope, and there are a single channel gastroscopes as well as double channel gastroscopes. And here is a gastroscope. All gastroscopes have the same length of insertion tube, but they vary in the insertion tube diameter. The larger the scope, the larger the insertion tube diameter, as well as the biopsy channel. So there are a number of different types of gastroscopes depending upon the insertion tube diameter and biopsy channel diameter. This is a typical adult gastroscope with a diameter of 10.9 insertion tube diameter, and the biopsy channel is 2.8 millimeters. Next, 9.9 millimeters, 2.8 millimeters. A smaller one, 5.8 millimeters, 2.2 millimeters. And the smallest one, 4.9 millimeters insertion tube diameter and a biopsy channel of 2 millimeters. If you want to do diagnostic procedures, therapeutic procedures, you want to pick a scope with at least 2.8 millimeter channel, because most of the accessories are able to go through that and you're able to deliver therapy. On the other hand, if you have a stricture and you want to take a smaller scope to examine, then you go with a smaller insertion tube diameter. So what does it involve? When you perform an EGD, the endoscope goes from the mouth through the pharynx, enters the esophagus, down the stomach, and the C loop of the duodenum, all the way to the third portion or even to the fourth portion of the duodenum. And you can identify pathology in the pharynx, esophagus, stomach, as well as duodenum. So let us look at indications for EGD. EGD could be used as a screening procedure in patients who do not have any symptoms or signs of a disease, and you are screening for a particular condition. We will go over that. It can also be used for diagnosis, especially if patients present with certain symptoms and signs of the upper GI tract. It could also be used for surveillance to follow up a particular disease. With advances in endoscopy can also be used for therapy, that is to treat. So let us look at the screening indications for EGD. So if you have a patient, especially someone who has a long history of acid reflux, if they're over the age of 50, obese, white male, smoker, drinks alcohol, you should think about whether they have Barrett's esophagus, and you should screen these patients. You should also screen patients with a long-term history of GERD for Barrett's esophagus. When you perform endoscopy in patients with long-term acid reflux symptoms to check for Barrett's, this is what you see: pink lining of the esophagus and the beefy red stomach lining or a columnar lining extends up into the esophagus. That is Barrett's esophagus. You have to confirm the diagnosis of Barrett's by taking a biopsy from the columnar lining marked by the arrow and demonstrate that there is intestinal metaplasia. So this is about screening GERD patients for Barrett's esophagus. Next, if you have a patient with cirrhosis of the liver and you want to screen that patient for varices, and when you perform endoscopy, you will see dilated veins in the lower esophagus, and here you have varices marked by the arrow. We see at least 2 big varices at between 12 to 1 and between 6 to 7, and also a couple more varices on the other walls. So in addition to screening for Barrett's and screening for varices, EGD is also used to screen for gastric cancer in Japanese and Korean Americans. And in this group, you do an EGD to screen for gastric cancer, and when you perform endoscopy, once you enter the stomach, you may see either precancerous changes or in some even an obvious cancer, as shown here by the star. You don't want to find cancer at this stage. This may be advanced and it may require surgery, chemo, etc. A lot of morbidity and mortality. You want to find this cancer before it becomes too late and in a stage where you could treat it by endoscopy. So we covered the role of screening EGD, GERD, Barrett's esophagus, cirrhosis, esophageal varices, high-risk patients for gastric cancer, Japanese Americans, Korean Americans for gastric cancer. Next, let's talk about the role of EGD in diagnosis. So let us look at certain clinical scenarios. So here is a couple. The husband has been having heartburn. He has taken omeprazole for a few weeks, but the heartburn has been persisting. In this case, you perform an EGD, and when you go into the esophagus, you're looking whether there is damage or not, that is erosive esophagitis, whether there is precancerous lining of the esophagus or not, that is Barrett's esophagus, and whether the patient has a defective mechanism that predisposes to free reflux, that is a hiatal hernia or not. So next, let us look at another patient who comes in with abdominal pain. He has taken some antacids, maybe famotidine over the counter, but the abdominal pain persists. In this patient, when you do endoscopy, you are looking for gastritis, that is inflammation of the lining of the stomach. You may see ulcers, either in the stomach or duodenum, or you may even see cancer. So patients with abdominal pain, especially upper abdominal pain, you perform an EGD to see whether any of these conditions are causing the abdominal pain. So now let us look at another patient who comes in and says that he has been having difficulty swallowing. And in this case, you perform endoscopy to see if there is inflammation of the esophagus that is making him have that difficulty swallowing, i.e. esophagitis, or if there is narrowing of the esophagus, i.e. stricture, either a benign stricture or a cancerous stricture, otherwise known as malignant stricture. And if there is a motility problem of the esophagus, a motility disorder like achalasia cardia. Let us look at another set of symptoms. Here is a patient who has come in saying that he has been bleeding from the gut. The bleeding could be vomiting of blood, or passing black stool, or passing bright red blood. Usually when somebody is passing bright red blood and is coming from the upper GI tract, they're very sick, their blood pressure is low, they may be seeing you in the emergency room. So, bleeding from the gut. One should think about whether the patient has liver disease and varices of the esophagus that bled, or someone who has been taking non-steroidal anti-inflammatory drugs or aspirin and bleeding from the ulcers, or if the patient has cancer. All right. Next, let us look at a young lady who has been who has come in with the weight loss. And when you think about weight loss in a young person, one of the things, especially if they have diarrhea also, one should take biopsies from the duodenum to rule out celiac disease. And always weight loss, keep in mind cancer. And someone may be afraid of eating because of pain and weight loss, then you think about ulcers. So, EGD can be useful in the evaluation of patients with persistent heartburn, upper abdominal pain, difficulty swallowing, vomiting of blood, weight loss, or diarrhea. So now let us go to how EGD can be used to treat upper GI conditions. Let me give you some examples. Here is a patient with cirrhosis who has come in with vomiting of blood from the varices, and you treat that by applying bands to those varices, and you can see the band here, and ligating the varices, otherwise known as band ligation. You could also see someone coming in with bleeding, especially black stools, from an ulcer, that is ulcer bleeding, and you could treat that ulcer bleeding either by cautery or applying a clip. Another therapeutic intervention in somebody who has been having difficulty swallowing and they have an esophageal stricture. This is a benign esophageal stricture, and you relieve that problem by doing balloon dilation. Another problem, again, difficulty swallowing. Here it is a cancer or malignant stricture, and you treat that by inserting a stent. In addition to treating bleeding, opening up the strictures, endoscopy can also be useful for treating tumors or precancerous lesions like Barrett's esophagus with dysplasia with ablation. Here is an ablation. Endoscopy can also be useful to provide access for nutrition, especially if somebody has lost weight. You could place a gastrostomy tube, and that allows the patient to have nutritional support through the gut. So in summary, we covered the types of scopes, indications for EGD, and now we will talk about adverse events during the procedure. During EGD, the anesthesiologist and the team will monitor carefully to make sure the cardiopulmonary status is maintained. They keep an eye on the rhythm, the heart rhythm, the blood pressure, the oxygen saturation. And they also keep an eye to make sure that the patient does not aspirate the oropharyngeal secretions. As far as the endoscopist is concerned, he should take care to avoid the risk of perforation to the gut and the risk of causing bleeding. So once the patient completes the procedure, once the procedure is completed, and as the patient comes into the recovery room without any adverse event, we tell the patient and the family, we provide some discharge instructions to make sure that the patient is safe and recovers completely without an adverse event. We ask them to call us for the following reasons. If they notice any bleeding, if they have any pain, fever, cough, shortness of breath, or any other bothersome symptom. By being proactive, we could avoid or minimize these adverse events: GI bleeding, perforation, aspiration pneumonia, and injury to adjacent organs. So let us briefly review some of the adverse events. How do we recognize them and how do we manage them? So in terms of the adverse events, aspiration pneumonia should be kept at the top of the list. If a patient aspirates during the procedure, they may have any of these symptoms in the recovery room, or when they go home within the first few days, they may have dyspnea, fever, and when they come, when you check their pulse ox will be low, they will be breathing quite fast, and if you perform an X-ray, you may notice shadows in the lungs. How do we prevent aspiration pneumonia? By being proactive. If you think there is a risk for aspiration pneumonia, anesthesiologists will consider protecting the airway by putting the patient under general anesthesia with endotracheal intubation to prevent aspiration pneumonia. On the other hand, if the patient undergoes a routine procedure without general anesthesia, one should keep the suction catheter at the bedside ready and suction the throat to prevent aspiration pneumonia. Next, another adverse event could be bleeding, and if it happens, the patient can come back or present with hematemesis, hematochezia, if it's a lot of bleeding, or melena. When there is a lot of bleeding, patients may feel dizzy and develop fainting spell or syncope. When they come into the hospital, their hemoglobin may be low. How do we manage these patients? These patients can be managed by a combined team effort with the help of interventional radiology, surgery, as well as endoscopy. So next, let's talk about esophageal perforation. Typically, when a perforation happens, usually experienced endoscopists can recognize during endoscopy. Sometimes if it is not recognized, when the patient comes into the recovery area, they may have chest pain, they may be short of breath, and their vitals may be off the chart. They may even have fever. When you do a chest X-ray, you may see air around the heart. If you suspect an esophageal perforation and the chest X-ray does not show perforation, you should go ahead and do a contrast CT chest. That will detect small perforations that cannot be seen on a chest X-ray. Here you notice air around the heart, that is pneumomediastinum. How do we manage esophageal perforation? Prompt IV antibiotics, keeping the patient nil by mouth, getting the help of an interventional endoscopist who could actually put a stent and seal off the leak. And if there is fluid collection in the chest, may need interventional radiology with a tube drainage of the chest. And in some cases, surgery may be required. Now, talk about gastric or intestinal perforation. Usually, experienced endoscopists can recognize the depth of resection and perforation. But if in case it's not recognized during endoscopy, when the patient comes into the recovery or during their time at home after discharge, they may develop abdominal pain, they may have fever, and when you do an X-ray, you may see air under the diaphragm. If you suspect perforation and you don't see air under the diaphragm, you should consider doing a chest, abdomen, and pelvis CT scan with contrast. And these patients should be given prompt IV antibiotics, kept nil by mouth. And in some cases, if you have interventional endoscopists that could manage, they should be consulted. Interventional radiologists may be needed to put the drainage tubes, and surgery may be needed. And these patients should be managed by involving all teams and coming up with the best plan for that particular patient. I hope this is useful. Thank you.